thanks so much for having me here. I'm really excited to be here and to present to everybody. Definitely about this topic. I love to talk about the influence of maternal exercise, especially for mom and baby. I want to give shout to our omics group. We have a metabolomics core at East Carolina University. And so Dr. Zizeki and Ashley Wooten, as well as my PhD student, have run a lot of this data for us, and it's still preliminary. I have no conflicts to present. And a quick disclaimer, Christy will appreciate this, but we do want to talk about the placenta, but we haven't run that data yet. So more to come on that and trying to find some answers to these questions. I do want to talk about prenatal programming. Again, Christy already introduced that idea related to the developmental origins of health and disease. And so in the US, what I usually talk to our students and our OBs about is that when women find out that they're pregnant, at least in the US, they're usually already obese. And so they can't change that, but we do know that the obesity is going to change the way the placenta is forming and the way the baby develops, and specifically the way the baby's organs are developing. And so again, as Christy said, rather than talking about disease and how we're programming, at least in the States, we're programming these kids to have obesity, we want to talk about physical activity and exercise and how can we improve these babies to be healthy, because we want to have super babies or at least healthier babies. And so for me, my big question is, what type of exercise is the best? We don't know. So we have somebody lifting weights. Is weights going to be the best, or resistance? What about aerobics, or is it a combination of both? And so with this particular study, this study is closed now, and so we're trying to analyze the data as quick as we can. But the design was we exercised the women at 150 minutes. That's our guidelines for America, and it's pretty similar for international guidelines. So 150 minutes of moderate intensity exercise, and then we were randomized. I have to be here. Sorry. Stay in my zone. So 150 minutes of moderate intensity exercise. Some gals were randomized to resistance only. Some were randomized to aerobics only, and then some were doing a combination. But all of them were doing 150 minutes of moderate intensity exercise compared to control women who were just doing stretching. And so for our timeline, we took our samples before they were randomized, and so right between 13 to 16 weeks, so right when they finished that first trimester. And then we did the training 3 times a week, every week, until we saw a baby. And then at 36 weeks, so right at the end, right before they delivered, we took another sample. And so this was maternal blood that I'm talking about for these samples. And then when the babies were born, there we go. We took measurements on the baby, but as Christy said, we also collect the placenta. So again, another picture if you haven't seen the placenta before, a couple seconds ago. And we take the umbilical cord cells because those are fetal cells. And then for us, again, we're interested in this programming idea. So if we see positive changes when the baby's 1 month old, do we still see these changes? Is the baby actually programmed to be healthier? And so I want to talk a little bit about metabolomics. So let me just give you a quick background on what metabolomics is. So on the left, we know where DNA comes from in our nucleus. That's going to code messenger RNA. Messenger RNA makes proteins. The proteins make metabolites. Okay, and that's really what we're measuring in metabolomics. Previously, what we did and what a lot of us do is we look at the phenotype of mom and baby, but we think we can do a little bit better. We want to see all the things that might be changing. And so that's why we took a step back and we wanted to analyze the metabolites with our metabolomics. All right. So now for the maternal blood, what do we see? And so again, this is our post-intervention study. And for metabolomics, if you really have different groups, what you want to see in these metabolites is you want to see groups clustering with themselves but separate from each other. And then that tells you they truly are a different phenotype. And so that's really what we're looking for. And again, when we run it through the core is blinded to what they're running. They just run samples. And so we run our plasma and our red blood cells separate, and indeed, what we see is we have 4 different clusters. So we have our 3 different exercise intervention groups and our controls completely clustering separate. So phenotypically, they are different, which is very exciting. And so then, this is preliminary, but we do have some pathways that are starting to hit and show significant differences amongst the groups. So I'm just going to hit the highlights. So relative to the non-exercisers, the aerobics have lower triglycerides. We've seen this before. They also have increase in phospholipids, so that phospholipid bilayer that everybody talks about in cell metabolism. The resistance-only group has an increase in arachidonic and linoleic acid. Those are associated with polyunsaturated fatty acids. And Christy already talked about the fatty acids a little bit, but polyunsaturated fatty acids are essential, and they're important for mom's development, they're important for pregnancy outcomes, and they're essential for baby's nervous system development. So it's exciting that they hit, and the combination group actually has a little bit of both of those groups. So it has lower triglycerides, increased fatty acids, but also has an increase in those polyunsaturated fatty acid pathways. And so again, polyunsaturated fatty acids are essential, important for mom and baby's development. For the resistance in the combination groups only, again, the omega-3s, part of that polyunsaturated fatty acid, those are upregulated, as well as arachidonic acid, which are omega-6s. So it's interesting that these pathways have highlighted. And then for all the exercise groups, they also have fatty acid activation and metabolism, fatty acid biosynthesis, the PUFAs again, and linoleic metabolism. So again, this is preliminary. We're still putting this together, and I think there's other pathways, but I think Christy and others find this kind of interesting related to the positive outcomes that we've seen associated with triglyceride being lower and fatty acids being improved metabolism. Again, one of our markers of interest was DHA. I don't know if you guys do DHA in your supplements, but in the States we have omega-3s. Yeah?
Yeah, I think so. Yeah.
So DHA is one of our omega-3s that's like in salmon and fatty kind of fish, and it's supposed to help with, again, nervous system development, cognition, heart health, right? Okay, so it's one of our markers of interest because of its importance in pregnancy outcomes and baby's development. So we do, besides a global run, we do a targeted run of metabolomics. And so I wanted to show you that data really quick, again, preliminary. So we have the controls in azul. We have aerobic in naranja, and we have combination gris, and then resistance in amarillo. I think I got that right. No differences in the group before they exercised, okay? But after the exercise, we start to see some differences in our preliminary data. And interestingly enough, all the exercise groups are actually higher, but the combination group is showing the best outcomes for mom's omega-3s. And when we look at her diet, there's nothing in her diet to explain this difference. So now we want to look at the baby side. So we see positive changes in mom. What about baby? And again, we're going to come back to placenta at like a year from now. So for baby, what outcomes do we see? We're still seeing 4 different clusters when we run baby's cells. These are cells from the umbilical cord, fetal cells. And again, we're seeing similar highlights in our pathways. So we see linoleic acid, phospholipid pathways. We actually have steroid hormone pathways, which are increased. And that's specifically from the aerobic exposure in utero. For the resistance-only group, we see a similar kind of pathway as what we saw in the moms. So linoleic acid, phospholipid pathways, for example, and arachidonic. And then the combination, we see the linoleic acid again, galactose, some of that sugar handling, and phospholipids. So it's very interesting. The ones that I have in bold are the ones that are similar regardless of the type of exercise that mom did. But we know that certain pathways are very specific for the type of exercise that she's doing. And so that's important, right? Again, for the infants, we also looked at those were fetal cells, so at birth. Now these are infants 1 month of age. And so we take blood from the infants, and then we run that as well. And fortunately, as far as prenatal programming, again, preliminary, but we still see our 4 clusters. So phenotypically, these babies are different still. And I was very excited when we started to look at the pathways that were upregulated, especially as exercise physiologists. The pathways that were upregulated for the babies at 1 month of age are associated with ATP and energy metabolism, very exciting. Cellular metabolism, phospholipid bilayers are again making substrates for gluconeogenesis is upregulated, as well as proteins and serotonin pathways. So a lot of these upregulations are very exciting from an exercise physiology perspective. And then the downregulated pathways were even more exciting. So, woohoo. They're excited too. So we have decreased pain and inflammatory pathways, which is huge when we think of trying to prevent obesity and all of these poor outcomes, because those are related to inflammation. So these babies exposed to mom's exercise have decreased inflammatory pathways already. as well as tumor and cancer homeostasis, which was interesting, and I don't study that, so that's just like right there. That's it. And what do you guys think is going to be the best as far as the DHA levels in the infants? What do you think is going to be the best group? Don't say controls. Combination, woohoo! Yeah, so again, we can see our similar groups here, aerobic only, our combination resistance. All of these are a little bit higher than our controls, again, preliminary, but the combination group is showing the best outcomes so far when babies are exposed to aerobic and strength exercise. Again, very clinically relevant when we talk to our pregnant women. And then 1 month outcomes, I just wanted to peruse these really quick, kind of in light of the metabolomics outcomes. What do we see in our babies phenotypically? And so all of these measures are going to be compared to our control babies. And again, these are 1 month olds. So resting heart rate, who do you think is going to have the best lower resting heart rate? Maybe. So resting heart rate, we can see it's lower in the aerobic exposed babies and the combination babies. Actually, the resistance babies had the best outcomes for resting heart rate so far. What about blood lipids? Probably something similar, right? So yeah, combination is showing the best. Our BMI Z-scores, these are corrected for age and sex of the baby. And you guys are on to the pattern now. So resistance and combination are actually the best improved for BMI Z-score. And then the cardiometabolic risk score. You might not be familiar with this, but the cardiometabolic risk score is a composite score, a summary score of 6 other scores. And it tells us what an individual's risk is of developing cardiometabolic diseases, obesity or heart disease and those types of things. So obviously a lower score is going to be better. You have lower risk of developing these issues, whereas a higher score is going to be poor. So who do you think is going to have the lowest score? Maybe, yeah. So resistance and combination are definitely the best. And then for babies, we're starting to, now that we have cool outcomes, I think, that's my technical term, the resting metabolic rate, or that resting energy expenditure of baby, we want to measure that as well. So what's baby's metabolism at 1 month of age? Is it improved or not? And we've only run our aerobic group so far, but our aerobic group has a higher resting metabolism of these babies even at 1 month of age. So again, very exciting work, and we haven't run our resistance and combination groups yet. Motor skills, so we've already published on motor skills, and at 1 month of age, actually for the US, it was in the news, and it was a news program on Good Morning America, and they were really excited that our aerobic babies had improved motor outcomes. That's not our strongest outcomes. You guys can guess what it is at this point. Our resistance and combination group has even better outcomes than our aerobic group, so that's pretty interesting. And then our next one, again, we're interested in that overall phenotype, but also at a cellular level, how does baby look, metabolically speaking? And so those stem cells from the cord, we can analyze those at birth, but then we can also differentiate them into muscle cells. And so they are acting like baby's muscle cells, and now we can stimulate them similar to taking a muscle biopsy, but we don't take a muscle biopsy from babies. That would be mean. And so what we did is we wanted to look at these baby skeletal muscle cells and see what is their oxidative capacity. How do they handle glucose and fatty acids? Okay, and what do you think we showed? Probably resistance and combination might be better. I have an equal sign there for aerobic, but technically our aerobic is better than our control group, but by far the better groups, as far as even at the cellular level, is going to be the babies that were exposed to resistance or combination. So again, overall, like in conclusion, our metabolomics is showing that there's differences, right? So there's some similarities that the babies are going to benefit regardless. You know, if mom does just aerobics or just resistance, the baby's going to benefit. If she does both, baby's going to benefit. But there are distinct differences in the types of exercise that baby's being exposed to. And I think this is a really interesting area to explore. Especially because some of our data doesn't always make sense. And so when we go back to the slide, here, let me go back, I'm sorry. Go back to this slide. The reason we're starting to see some of our differences is because we focused on our obese, our overweight, obese women. Our healthy weight women, they're doing pretty good. Their babies are doing pretty good, right? But when we focus on our overweight, obese population, we really start to see these distinct differences. And for Americans, a lot of times when the OBs know that the women are diabetic or have a high risk of diabetes, what do they tell them to do? Go for a walk, right? They don't tell them to go lift something. And so here, this is telling me that we might need to think about not just the type of exercise, but what about the type of person that it is. If it's an obese mom, maybe you should be telling them to do both. And so that's really important. And I didn't present it here, but also we have differences in our Black women versus our Caucasian women. We see differences, and the Black women definitely, they're physiologically speaking, prefer resistance and combination exercise as well. So this is a really important picture that we're trying to put together on what should we be telling each specific pregnant gal what to do. So next steps, we are going to analyze our placenta data. As Christy knows, it takes a long time. So hopefully by next year, we'll have some of that data, because that's really, as Christy said, it's really the mediator. We see positive things for mom, we see positive things for baby. So what's happening at the placenta to make those changes? Especially for my work, why is the placenta changing things differently when they're doing resistance only versus aerobics only versus both? Okay, and so I'm really interested to find out what's going on with the placenta as well. We have a huge group of people, lots of OBs, physical therapists that we work with, cardiologists that we work with, and a ton of students. Plenty of students are now faculty member, but we also have about 5 PhD students, 5 master students, and a ton of undergrads that help us collect all this data and do the exercise training. Super fun. Oh, and I have to give kudos. We have American Heart Association funding. East Carolina University supports me, and now we have NIH funding from our government. So thank you for your time.
Good morning, I'm Pilar Chavez. I'm a second-year OBGYN resident at Hospital Puerta de Hierro, and today I'm going to talk about exercise and its effects on several components of labor, specifically mode of delivery, duration of labor, and perennial tears. Regular physical activity in all phases of life, including pregnancy, promotes several health benefits. The American College of Obstetricians and Gynecologists makes the following recommendations. Physical activity and exercise in pregnancy are associated with minimal risks and have been shown to benefit most women. Women with uncomplicated pregnancies should be encouraged to engage in aerobic and strength conditioning exercises. And studies recommend at least 150 minutes of moderate intensity aerobic activity per week. The benefits of exercise in pregnancy include a higher incidence of vaginal delivery and a lower incidence of excessive gestational weight gain, gestational diabetes, gestational hypertensive disorders, preterm birth, cesarean birth, and lower birth weight. So first, in terms of mode of delivery, C-sections are associated with longer hospital stay and increased risk of infection for the mother, higher chance of respiratory distress in newborns, and greater morbidity and mortality for both mother and child. Rajabi et al. Carried out a cohort study design with 2,029 pregnant women recruited at 18 to 22 weeks of gestation, who were asked to recall their levels of physical activity before pregnancy. 66% of women underwent C-sections and 34% had normal vaginal delivery. The odds ratio of C-sections was 0.68 for a pregnant woman who increased her level of physical activity during pregnancy compared to before pregnancy. The results of this study showed that regular and standard physical activity during pregnancy can reduce the risk of cesarean section. A prospective study by Da Silveira et al. Involved 66 premenopausal women who were divided into 2 groups. An exercise group, which engaged in regular physical activity lasting 50 minutes twice a week starting at the 8th week of gestation, and a control group, which did not participate in physical activity. The group that did engage in regular exercise had a higher rate of vaginal deliveries compared to the control group, with a statistically significant difference. A systematic review and meta-analysis by Potayos et al. Examined the influence of physical exercise interventions on mode of delivery of healthy pregnant women. 10 randomized controlled trials were included in the meta-analysis, and main outcome measures were mode of delivery, normal, operative, or cesarean delivery, and physical activity. The evidence suggests that physical exercise during pregnancy may increase the likelihood of normal delivery, in particular during the 2nd and 3rd trimesters, even reducing the risk of cesarean delivery. On the other hand, many studies suggest that prolonged labor is associated with increased maternal and perinatal morbidity and mortality. From a scientific point of view, there are many factors affecting the duration of labor, such as maternal characteristics and obstetric parameters, which include body mass index, maternal age, parity, the use of oxytocin, epidural analgesia, and induction. From a clinical point of view, childbirth has been divided into 3 stages, with most studies indicating that the majority of perinatal complications are associated with a prolonged second stage. Rodriguez Blanca et al. Published a randomized trial with 140 healthy pregnant women divided into an exercise group and a control group. The intervention program took place between week 30, week 20, and week 37 of gestation, and it included 3 60-minute sessions of exercise per week. At term, 63% of the women in the exercise group and 56% of those in the control group had a vaginal birth. The average total duration of labor was 389 minutes for the women in the exercise group and 561 for those in the control group, which is a difference of approximately 3 hours. The difference was especially marked with respect to the duration of the first and second stages of labor. In the first stage, there was a difference of 2 hours and 25 minutes between the exercise group and the control group, and the difference of 1 hour for the second stage was statistically significant. In a randomized clinical trial by Barakat et al., 508 healthy pregnant women were randomly assigned between weeks 9 and 11 of gestation to a control group or an exercise group, which followed a moderate aerobic exercise program of 3 weekly sessions of 55 to 60 minutes. The primary outcome studied was the length of the stages of labor. Women randomized to the exercise group had a shorter first stage of labor, total duration of labor, as well as combined duration of first and second stage of labor. The probabilities of a woman being delivered at 250 minutes and 500 minutes were 19.1% and 62.5% in the experimental group versus 13.7% and 50.8% in the control group. A study by Gotzi et al. Aimed to evaluate the effects of exercise on duration of labor and perineal tear rates among pregnant women. 174 women with a singleton pregnancy were selected during the 20th week of gestation and assigned into a training group, consisting of a light-intensity exercise program which lasted 30 to 45 minutes 3 times per week, or a control group. There was a meaningful difference between the train and control group in the duration of the first stage of labor, but the difference was not statistically significant when evaluating the duration of the second stage. However, the majority of people in the training group had a second stage length between 20 and 30 minutes versus 31 to 40 minutes in the control group. And finally, in regards to perineal tears, women frequently suffer perineal tears while giving birth, particularly during their first delivery. Perineal trauma is defined as any damage to the genitalia during childbirth, either spontaneously or due to an episiotomy, and is associated with short and long-term morbidity. Perineal damage may result in urinary and fecal incontinence, painful intercourse, persistent perineal pain, and weakness of the pelvic floor musculature. Furthermore, women who deliver with an intact perineum report less perineal pain immediately after delivery and better sexual function 3 months postpartum. In the study by Gotzi et al., data regarding perineal tears was also collected. Episiotomy rates, overall spontaneous tears, and intact perineum tear rates were similar in the study and control groups. The rates of intact perineum were significantly higher in the trained group, and women in the training group had a slightly lower rates of second-degree tears, although both of these outcomes did not reach statistical significance. Silva Jose et al. Performed an observational prospective study in which 62 pregnant women were interviewed during the last trimester. The physical activity questionnaire was used to determine the level of physical activity, and data regarding perineal tear rates was collected. The cutoff point for active and non-active women was established to be 225 meds per week. 54% of the pregnant women suffered tears, and there were no type 3 nor 4 tears. Results showed a lower perineal tear rate in those women in the active group. Significant differences were observed between study groups in the percentage of tears as well as the percentage of type 1 tears. In conclusion, several anatomic and physiological changes occur both during pregnancy and labor, and it is an ideal time for behavior modifications and adoption of a healthy lifestyle because of increased motivation and access to medical supervision. Apart from all the well-known benefits of exercise, it has been demonstrated that women who exercise regularly have a greater probability of vaginal delivery and a decrease in the number of cesarean delivery and operative vaginal delivery. This is relevant as cesarean sections have a higher risk of infection for mothers and longer hospital stays, as well as a higher chance of respiratory distress in newborns. Regular physical activity during pregnancy shortens the duration of the first and second stage of labor, which is important as prolonged labor has been associated with increased maternal and perinatal morbidity and mortality. And finally, the rate of intact perineum is significantly higher in those women who practice regular exercise during pregnancy, helping improve urinary and fecal incontinence, painful intercourse, persistent perineal pain, and weakness of the pelvic floor musculature.
Okay, so good morning, everyone. My name is Cristina Silva. I am doing here my PhD candidature with Ruben Barakat Lab in this university. And first of all, I would like to thank you, Ruben, for this opportunity, for share my position here with all of you. So today I'm gonna explain one of our last works entitled Influence of a Virtual Exercise Program Throughout Pregnancy During the COVID-19 Pandemic in Perennial Tears and Episiotomy Rates. Oh. Okay. To begin with, the evolution of the human being supposes a clear disadvantage for the pregnant women by shortening the cross-sectional section in the pelvic cavity, and this makes it difficult the childbirth for the fetus. This can lead to complications during this moment, being perineal trauma the most common, and it occurs in 85%, and this is the international rates of perineal trauma. And this is a very, very big problem because it supposes a problem in the healthcare systems and all the costs that this is related about. Okay. Perineal trauma are composed in spontaneously or intentionally type of trauma. In the one hand, the perineal tree, it is composed of there are four types of perineal tears that they are ranked from least to greatest severity. And then the episiotomy, that it is an intentional procedure, a surgical procedure, and the episiotomy doesn't prevent a perineal trauma. And this is an important thing that I want to say that. These traumas are extremely important because they can lead in different problems in the life of the women. For example, urinary incontinence, anal incontinence, sexual dysfunction, pain, obviously the pelvic organ prolapse, and all of that are related with one of the things that we love to study, that it is depression, and in this case, postnatal depression. And all of that affects and can affect to decrease the quality of life of these women, not only in the postpartum, both in all their life. So therefore, it is vital to find some prevention strategies instead of having a recovery of the injury. And in this point, our group or intervention will wanna focus in the primary help with the women. This is when we want to stay. And for now, and with this, our starting point, it begins 4 years ago. It was doing an observational study that Pilar told before, and we found, like she said, more frequently the perineal tears and more severity in the active group, in the non-active group in our sample. We found that, and then we have a problem. The COVID-19 appears, and we have to change. It was a challenge for us, and we have to change all things. And this COVID situation led to lifestyle changes in the pregnant population, and then they can derive in health problems. So with all of that, we propose and we want a study. We want to do a study with the objective to examine the influence of a supervised virtual exercise program that we are doing right now throughout pregnancy on perineal injury and in episiotomy rates. For this work, this is the trial timeline. We designed a randomized clinical trial with the data from 3 different hospitals. This paper is before it is from the beginning of our project. And we have around 50 women in each group for analyzing. I want to explain what we do with all the groups. And in the first one, in the control group, we are in constant communication by WhatsApp, and this group receive standard care in their hospitals. They must accomplish with a decision algorithm to remain in our study, and they receive different recommendations of a healthy lifestyle. It is only recommendations. For example, like you can see in this video, how to get up from the floor. In the intervention group, they receive also these informations, but they participate in a supervised group, supervised classes following the international guidelines, Canadian, American, and Spanish, and the structure of the class is based on the Barakat structure model. We made 3 weekly sessions, controlling the workload intensity with the maternal heart rate and the Borges scale, and then we saw the adherence to these classes in the 8%. The intervention group, these 3 classes. The first one is an individual session following a YouTube video adapted to their gestational age, and we have a private list for them. And then the second ones are from 2 Zoom sessions, Tuesdays and Thursdays, that all of you are invited if you want to see one of them, and in the morning and in the afternoon. Also, the women can adapt their schedule to her lives and all of that. So they can choose but they are not allowed to participate in the class the same day. Okay. These are different examples of our Zoom classes, and I want to focus in that it is a specific pelvic floor part that we work in the classes. The first one is aerobics, muscle strengthening, balance and coordinations. Well, this is muscle strengthening and pelvic floor. And with that, we found the results. We found that both in the Perennial Tears and in episiotomies have more frequent these injuries in the control group, and the severity of these injuries is more often in the control group as well. Similarly, we made an analysis dividing the sample depending on the mode of delivery, instrumental or non-instrumental delivery, and we found that perineal tears are significantly higher in control group in non-instrumental deliveries, and episiotomies are significantly higher in the instrumental deliveries. And at last, we made a 2 matrix of correlations that one for each group of the study, and we found interesting things here. The first one is for both groups, we found that episiotomy are negatively correlated with the perineal tear type, and newborn dimensions are correlated positively with the mode of delivery and with the perineal tear type. So a baby that it is bigger can lead a perineal tear or an episiotomy. And then when we focus in the control group, we saw that the mode of delivery are positively associated with episiotomy and negatively associated with perineal tear type. final, to conclude and to expose here, together with the previous scientific literature, we could we could know that doing specific exercise and maintaining adequate levels of physical activity throughout pregnancy could help to, or may perhaps protect, the perineal area. And as a result of our study, we could conclude that our virtual supervised exercise program throughout pregnancy during the ongoing pandemic reduce the injuries to the pelvic floor during childbirth in healthy pregnant women, that it is the population whose we work with them. And then, at last, in this slide, I let you the reference of the study, and I finish my presentation. Thank you very much.
Hello, everyone. Can you hear me okay?
Yes.
That's good. Well, hola. I am from Canada, so it's amazing what technology will do when it works properly. My name is Michelle Matola, and I'm the director of the Exercise and Pregnancy Lab at Western University. And I want to, first of all, thank Ruben for inviting me to speak today, and also to thank the organizers of this great event. It is very early in the morning for me, so forgive me. I have had my cup of coffee, but it's very enjoyable to be here. So thank you very much for the invitation. So today I'm going to speak about gestational diabetes mellitus and exercise, and specifically looking at prevention and management with regards to gestational diabetes. And hopefully I will be able to advance my slides. Okay, good. So as you know, gestational diabetes is a form of glucose intolerance that's first diagnosed during pregnancy. And during pregnancy, we do see a normal insulin resistance occurring in the mother, as well as a higher blood glucose. And that's for fetal growth and development, because the fetus uses maternal blood glucose for its growth and development. But that's normal, that's natural. And this results from hormonal changes during pregnancy. But if there are risk factors present, so for example, if she has a history of gestational diabetes or a history of diabetes in her family, the fact that she becomes pregnant may actually tip the balance. And so she may become gestational diabetic if these risk factors are present. And right now, the cause for gestational diabetes is unknown. It could potentially be a combination of genetics and also potentially lifestyle. So with gestational diabetes, the individual is unable to maintain their control of blood glucose values through lifestyle, and they may progress to insulin injections if they are not able to control their blood sugars within 2 weeks of being diagnosed. And we now know that before it was said that as soon as the baby is born, gestational diabetes disappears, but we now know that potentially up to 60% of individuals will develop true diabetes or type 2 diabetes within the first year after delivery. So it is very clear now that gestational diabetes does not necessarily go away after the pregnancy. And so individuals who have had gestational diabetes in a previous pregnancy are at increased risk for gestational diabetes in subsequent pregnancies. And the more pregnancies with gestational diabetes, the more at risk they are for developing diabetes later in life. And there's also a potential risk for the offspring. So those babies that are born to individuals with gestational diabetes are more at risk for type 2 diabetes later in life, being born big or macrosomic, so babies born greater than 4 kilograms, and they can also be at risk for developing obesity later in life. And this comes back to the developmental origins of health and disease, or DOHAD, where the fetal environment is extremely important with respect to what happens downstream in that particular baby. So the question here is, does exercise prevent gestational diabetes? And we know that there are specific things that happen during pregnancy, and there are specific things that happen with exercise. And when we combine the two, can exercise actually prevent gestational diabetes? We published a systematic review and meta-analysis a few years ago where we examined whether or not exercise prevented gestational diabetes and hypertensive disorders. I'm only going to focus on gestational diabetes in this talk. So there were 106 randomized controlled trials that were analyzed in this particular systematic review, and we found that exercise reduced the odds of gestational diabetes by 40% compared to those individuals with no exercise. And we also found that to achieve at least a 25% reduction, the individual needs to have at least 140 minutes of moderate intensity physical activity per week. And I know the guidelines suggest 150 minutes per week, but we found that in order to decrease that reduction by 25%, 140 minutes of moderate intensity exercise per week is what was necessary. And this included, for example, brisk walking, water aerobics, stationary cycling, or resistance training. So I want to share with you a study that we did a number of years ago where we actually took a look at individuals that were at low risk for gestational diabetes and those individuals that were at high risk for gestational diabetes. And we randomized them into two intensities. So the low risk exercising, low risk individuals were randomized into a mild intensity at 30% of heart rate reserve or a moderate intensity activity, and the program was walking. That was at 70% of heart rate reserve. And then we also took those individuals that were at high risk for gestational diabetes and again randomized them into either a mild or moderate intensity activity group. All of these individuals received nutrition control, so they received a gestational diabetic diet, and the only difference between the groups were whether or not they were at risk for gestational diabetes and what intensity of activity they were actually engaged in. So as I've mentioned, it was a walking program. So we started the individuals off at 25 minutes of walking and then added 2 minutes per week until they reached 40 minutes, and then they maintained that until delivery at their particular intensity. We took a look at capillary glucose responses before and immediately after the exercise using a glucometer. And so when we actually looked at these individuals, we looked at them at 16 to 20 weeks of pregnancy when they first started the program, and they were exercising at that point at 25 minutes. And so we looked at pre versus post activity at 25 minutes. And then at 24 to 28 weeks of pregnancy, they were now up to 35 minutes of activity at their specific intensity. And we looked at them then. And then the last time was we looked at 34 to 36 weeks of pregnancy in the later stages. And they were now up to 40 minutes of activity. So this is showing you the demographics of the individuals. So this is the low risk women on the left here at the mild or moderate intensity, and on the right is those women at risk for gestational diabetes, again at the mild or the moderate intensities. And what you'll notice here is that those individuals at risk for gestational diabetes actually had many risk factors, and they also were heavier, they had a heavier pre-pregnancy body mass index, and had heavier body mass going into the intervention. And down on the bottom on the right here, you can see risk factors for gestational diabetes. So several of our individuals that were at risk had several risk factors. For example, family history of diabetes, history of gestational diabetes or polycystic ovarian syndrome, previous baby that was macrosomic, and a pre-pregnancy body mass index of over 25. Now these next few graphs are going to show you the capillary glucose responses pre versus post exercise. And in this one, it is at the beginning, so just before and after 25 minutes of walking and at the 16 to 20 week gestation mark. So the graph shows you on the left here, low risk individuals at 30%. Next is low risk individuals at 70%. Then we have risk individuals at 30%. And finally, risk individuals at 70%. And you can see that there is a drop in capillary blood glucose before and immediately after exercise for 25 minutes in all 4 of the groups. When we then look at what happens when they walk for 35 minutes at 24 to 28 weeks of gestation, again we see a drop immediately after exercise in all 4 of the groups. But the interesting thing is when we looked at the glucose response to walking at their specific intensities when they were up to 40 minutes of activity, and now in the late stages of pregnancy, we see again a drop in all of the groups except for the one that was at risk and engaged in 70% or moderate intensity physical activity. There was no difference pre versus post exercise in this particular group. So what this meant to us was that maybe to achieve the best decline in capillary glucose concentrations, those individuals at low risk for gestational diabetes should maybe walk for at least 25 minutes, and it can be either at low or a moderate intensity activity. However, for those individuals that are at risk for gestational diabetes, perhaps now we might maybe begin to see a difference. And so maybe those individuals at risk for gestational diabetes should maybe walk for 25 minutes per session at the moderate intensity, or walk for 35 to 40 minutes per session at the mild intensity. And again, remembering from our previous study that if you can continue this activity for at least 140 minutes per week, at least, then maybe we can see a difference in those individuals at risk. The other thing I want to mention here is we also looked at whether or not the mild intensity confers an aerobic benefit. And indeed, we found that it did. So again, we did another study where we looked at intensity here with the 30% of heart rate reserve, so the low mild intensity, versus the 70% heart rate reserve, moderate intensity. And we found indeed that even walking at that mild intensity does confer an aerobic benefit. So walking is a marvelous aerobic activity. So the question then becomes, how low can you go to make a difference in blood glucose values in those individuals at risk? And so suggesting here is at least 140 minutes per week, and it can be a mild intensity activity. We published this, I published this with Raoul Artel a number of years ago, where we actually took a look at the literature. And what we suggest here when we look at frequency, intensity, time, and type, the FIT principle, that frequency in those individuals at risk for gestational diabetes should be at least 3 times per week, can be either mild or moderate intensity. The duration, again, depending on the intensity of the exercise, so it can be 35 to 40 minutes for the mild intensity, or 25 minutes per session at the more moderate intensity activity. The type can be walking or an aerobic activity, but I think the point that's very important is that the activity should be moving large muscle groups. And it can be body weight supported, such as stationary cycling or swimming, or it can be a walking program where body weight is incorporated into the activity. So the next question here is, does exercise assist in glucose control in individuals that have been diagnosed with gestational diabetes? And again, we published a systematic review and meta-analysis a few years ago where we actually looked at glucose responses to acute and chronic exercise during pregnancy. And in this particular systematic review, we looked at 58 studies, and we found that acute exercise that was associated with a decrease in maternal blood glucose before and up to during and after exercise. And we also found that there were larger decreases in blood glucose in individuals with diabetes compared to those without diabetes. And we also found that chronic exercise reduced fasting blood glucose compared to those individuals with no exercise. And so the conclusion from this study was that acute and chronic prenatal exercise reduced maternal circulating blood glucose concentrations, with the larger effect occurring in those individuals that were diagnosed with gestational diabetes. I want to share a pilot study that we did a few years ago, where we actually took a look at structured low-intensity walking activity on capillary glucose concentrations and insulin requirements in gestational diabetic individuals. And we had a control group and we had a walking group, and we matched these two groups by age, pre-pregnancy body mass index, and insulin usage. We put pedometers on our walking individuals, and we found that these individuals basically took daily steps of about 6,500 steps per day. And then we started them on the same exercise program previously. So we started them at 25 minutes, and then we added 2 minutes per week until they reached 40 minutes. And we found that when they walked for 25 minutes, they actually walked, they had 2,600 steps that they took just from walking 25 minutes. And at the 40-minute mark, we saw that at 40 minutes, they took 4,200 steps. And so when you add the 4,200 steps to what they did on a daily basis at 6,500 steps, we actually got them to walk 10,000 steps on a daily basis, and that brought them into the activity index. So they were being very active at the end of pregnancy. And I want to share with you the capillary blood glucose values from diagnosis of gestational diabetes to the last week before delivery. And what you can see in this graph here is on the bottom is fasted blood glucose 1 hour post-breakfast, 1 hour post-lunch, and 1 hour post-dinner. And this is showing you the capillary glucose responses pre and post-intervention. And so what we have here with the first arrow in black is the individuals who walked, and the white beside it is the control individuals. And the arrows are showing you what happened at the end of the intervention. So you can see the fasted is pre versus post. We saw a statistical difference in the amount of blood glucose in the fasted state. We also saw a statistical difference in 1 hour post-breakfast, 1 hour post-lunch, and 1 hour post-dinner in the individuals who walked. We also took a look at the amount of insulin that these individuals were injecting. And remember, they were matched by insulin at the beginning of the intervention. So at the end of the intervention, what we saw in black here is the insulin injection at breakfast, lunch, dinner, and bedtime for the control women, whereas the white bars are showing insulin injections for the individuals who walked. And what we found was that those individuals who walked actually had a lower insulin injection per kilogram body mass. And again, Raul Artel and I published best practice guidelines for those individuals that were diagnosed with gestational diabetes. And again, looking at the literature and incorporating frequency, intensity, time, and type. And what we suggest here is that frequency for walking for those individuals with gestational diabetes at least 3 times per week, preferably after a meal. Intensity can be either 30% or potentially up to 60% of heart rate reserve. And the duration, if it is that mild intensity, they can start at 25 minutes, increasing by 2 minutes per week until they reach 40 minutes per session. And the type, again, walking or aerobic activity, moving large muscle groups. And I think that is the key, that moving large muscle groups to get that blood glucose into the muscle cells. So with regards to future work, not a lot has been done with regards to gestational diabetes, and I think this is a really important thing to take a look at. We need to understand the mechanisms behind why it might be different with regards to prescription for those individuals at risk for gestational diabetes versus those who are not. And also those individuals that are diagnosed with gestational diabetes. Are they different than non-risk individuals? And our preliminary data would suggest that indeed they may be different, and there may be different mechanisms at play with regards to physical activity, and in particular looking at intensity. What about nutrition? I think nutrition is extremely important, and the combination of exercise and nutrition is very important with regards to those at risk for gestational diabetes and those individuals that have been diagnosed with gestational diabetes. And it's also very important that we consider outcomes, specifically looking at outcomes of the mother, especially in the postpartum period, and also outcomes in the babies. And of course, follow-up. And I think follow-up is extremely important. What happens to these individuals further down the road with regards to 1 year postpartum and beyond, and also the babies at 1 year post-delivery. And I want to thank and acknowledge co-investigators that I've been working with over the years, former students, present students, and our exercise and pregnancy lab team, and of course all of our funding sources, because I could not have done any of this work alone. So it definitely is a team effort. So again, acknowledging all of those individuals. And I think we're ready for our panel discussion, so be very happy to join the panel and to answer any questions you may have. So thank you very much for your time. I definitely appreciate it.
Well, it's too late, but we can start the roundtable with a question to Michelle. Have you got any question to Michelle? To Michelle, no. Not to Michelle. And to, have you got any question about any lecture? No? No. Yeah? You sure? Oh. Michelle, no question for you. Tanya has a very, very difficult question for you. Okay.
Hi, Michelle. I know I could ask this whenever I want, but I'm going to ask with everyone here. I was just wondering, and we've experienced this when we've published papers as well, that if the guidelines say 150 minutes, why then do we go up to 40 minutes 3 times per week? Because that would get us to 120. So how do you respond to those comments? Because it's always changing. Sometimes we say 3 times per week, other times we say as many days of the week as you can. So how do we get more specific with guidelines, or should we be more specific?
Great question, thank you. I think the guidelines are on low-risk pregnant individuals. And so the reason that we had to kind of do that in a general sense is because we wanted to provide guidelines for the general population. But I think you're right. I think, and hopefully that's kind of something that you see from the data that I've suggested here, that those individuals who are at risk for gestational diabetes, or those individuals who have gestational diabetes, maybe we should start considering those as a special population group of pregnant individuals. And the reason is because what we're potentially seeing is that maybe intensity makes a difference, and so potentially does duration. And so I think we need to consider this, and that's why I think we still need to do a lot more work with regards to what is happening mechanistically with regards to those individuals at risk and those individuals that actually have been diagnosed with gestational diabetes. So great question, and hopefully I've stimulated all of the people in the audience so that you can go and do some work with gestational diabetic individuals or those individuals at risk for gestational diabetes, because definitely more work needs to be done here.
Thank you.
No more question? No? Well, I have not a question. I have just only a reflection. I was talking with Linda about what do you think when you write in English resistant exercise. ¿Qué pensáis que es un ejercicio de resistencia? Fares, Marcos, ¿sí? We need to clarify because it is a very important confusion for us. We have to clarify the term of the type of exercise above all when we write a model, because for us is a similar the similar meaning resistant exercise and aerobic exercise, and not in English. This is important confusion for us. Huh? So we have to talk about that. Okay. Any more question? No. Any more reflection? No. Complaint? No. Okay. So thank you very much, everybody, for your presence and patience. In Spanish, it's similar, exactly similar, resistant exercise and aerobic exercise. Above all, when we are talking about the resistencia aeróbica extensive. So it's dangerous for us when we want to write in English an article or something like that. It's a typical correction for us from reviewers. Reviewers are bad people. Huh?
I'm going to talk about that.
Okay. Rita's going.
I can edit your papers for you.
Okay. So let's go to have a lunch. Okay. Thank you very much, everybody. See you tomorrow. Bye. Adiós. Gracias.